Good afternoon, everyone. Welcome to our webinar series, Conversations about Living and Dying. It's a series with experts on issues related to living and dying well. Our speaker today is Dr. Amanda Landers from the Nurse Maude Hospice Palliative Care Service. She's a community palliative care physician and she's also a lecturer at the University of Otago Medical School. Welcome, Dr. Landers. Over to you.
Thanks, Renee. Thank you, those of you who have joined in today. We thought we might talk a little bit today about the 10 myths of palliative care in New Zealand. There are a lot of misconceptions and thoughts about what palliative care means in the community, what hospice is, and quite often when people see us coming up their garden path, they perhaps feel anxious, that it has some meaning attached to it, and we spend a lot of our time talking through how we work, why we do the job that we do, and I thought today we might go through some of the very strong myths that are out in the community. Hang on, just getting to grips with the... So, I just wanted to show you what the projected death rate is in New Zealand. These are statistics from the Ministry of Health. The bottom is from 2014 going across to 2026. So we're actually in the midst of this graph in the third bar there. Now, you don't need to worry about the numbers too much. The dark blue at the top are those that are going to die aged 85 and over. And you can see that that number, or that bar graph, just continues to increase year on year. The light blue is age 75 to 84, and that stays pretty much the same as you go along those years. But you can see that the light yellow at the bottom there, which is the ages under 40, actually gets smaller. So that all means that we'll be dealing with people at the end of their lives who are very old or very elderly, and therefore have a lot of problems, a lot of symptoms, and need our care and attention and understanding as we look after them as they move into this time of their lives. Also interesting is where people actually die in New Zealand, and this was from 2000 to 2010. There were 300,000 deaths plus. And you can see there that it's about a third. So about a third die in hospital, which is actually a reasonably low number in the OECD countries. About a third die in residential care, commonly known as nursing homes, although that's not a term I particularly like using. We would tend to call it residential care or aged residential care. And the light yellow there is home. So that's probably about 25% of people die at home. So if you add up the fact that we would see residential care as being somebody's home and a private residence, it's well over half of our population die outside of a hospital facility. So what is palliative care? And I've really been taught by many of my patients as to how this is best described to people. And reasonably recently, I had a youngish Maude patient who asked me this question in her home: what is palliative care? And as I talked to her, I realised that the word palliative comes from the word palladium, which is Latin and means to cloak. And when I said that to her, it really resonated with her, because in the Māori world, a cloak is of huge significance, no matter which iwi you come from. And it means honour and care and warmth and love. And that's really what palliative care tries to do for people, is to wrap them in a cloak of support and advice and understanding, and their families with education and support as well. So if we look at palliative care like that, hopefully it's not quite as scary, and it can be really helpful to explain it to people in this manner. But the really important message, if you take nothing else away from me today, is that palliative care is everybody's business. Everyone plays a role, from the smallest child right through to the oldest person in our community and in our society, in helping care and support and love people who are at the end of their lives. For myself as a specialist, it's what I do day in, day out as part of my job, but really I'm here for the complex and for the ones that have lots going on that needs to be balanced and understood. But really, it's important that everyone has a basic understanding of how to care for someone at the end of their lives. And obviously, linking into the seminar would show me that you are one of those people that wants to know a little bit more. There's really 3 forms of palliative care, and this is really quite important. The first one I've already explained is the palliative approach. So it's anybody coming into somebody's life who is getting more unwell and really understanding how to support and advise them. The next one is specialist palliative care services, and that's people like myself who train particularly in palliative care as a specialty and do extra training and extra education and work within a specialist service. So part of my job, I became a doctor in 2000. I went into my junior years at various small hospitals around the country. Then I came to Christchurch in 2004, and that was the first time I could do palliative care as an actual rotation. I then sat my physician exams. I could have gone and been a heart doctor or a lung specialist or a cancer specialist, but I chose to do palliative care as a specialty instead. I work with doctors, other doctors, nurses, dietitian, physiotherapy, occupational therapy, spiritual care, family support, a whole raft of people. And we work as an interdisciplinary team. So we flow in and out of each other's roles depending on the person's need that we're sitting with and caring for. Probably the third form of palliative care, which is the one most people associate with us, is end of life, or the word terminal care. Now, I find the word terminal a bit confusing and quite hard to understand and use in the community. The word terminal can really mean anything from the last hour to the last year. And when you see people interviewed in the media, they're often sitting there having a cup of tea saying to the reporter, "Oh, I'm terminal." So I don't think it's a very easy term to understand. The phrase end of life is one that probably should be reserved for the last couple of days. And if we all stuck to that terminology, we would probably understand it better. So end of life care is probably that last 48 to 72 hours. The palliative approach is really towards anybody that has an illness that cannot be cured. And specialist palliative care services are those that are there to support anyone with complex needs, and they have extra training to be able to do that. Palliative care really came out of the hospice movement happening in New Zealand around the 70s. St Christopher's in England, led by Dame Cicely Saunders, was the first. She was really the mother of palliative care and hospice care in the world. She had first been a nurse and then had become a doctor later on, and her life's really fascinating. The main focus when the palliative care movement came to New Zealand was on cancer, but I'm going to break that myth today about the fact that we only deal with cancer patients. A lot of what palliative care offered was time and attention, and we still to this day try to do that. We work in a busy environment, but we know that the best thing we bring to the table for people is time and a listening ear and understanding what's going on for people. We build strong therapeutic relationships, but it's really important to understand something as simple as a smile or a touch or a nod can build therapeutic relationships too. It does not need to be intense and involved, and it doesn't even need to involve words. It's really being alongside somebody and being empathetic to them. We do have huge challenges though in palliative care. We have a growing need, as you can see from the graph that I showed you at the start. We also have increasing complexity of patients. I think this is a really important thing to understand. As medicine improves and treatments improve, people live longer with their illness. And sometimes that means that they get more and more symptoms and more complexity around finances, families, social issues, and there's more and more complexity as time goes on. I've even seen it in the decade that I've been doing palliative care. So one example would be that men with prostate cancer. Prostate cancer likes to go to the bone, and quite often men with prostate cancer live a long time, many years, and they get more and more spread to the bones. We really didn't see prostate cancer going anywhere else because, of course, men would die eventually, either of their prostate cancer or with it. But now, because of treatments, because of chemotherapy designed for prostate cancer, we're now seeing issues like the prostate going to the brain, very rare, but we never used to see it before. And it means that we then have to help families and patients deal with that aspect of their illness, which we didn't have to before. So you can see things are changing and moving all the time, and we in the palliative care services try and keep up with new and improved medicines that are available. People have quite different expectations. We find sometimes families have different expectations to patients. Sometimes medical staff have different expectations than what patients have. And so there's a lot of trying to meet in the middle, a lot of trying to explain what's possible, what's probable, what's not possible in the context of these illnesses. We're always trying to strive for equity. I was just working in a very remote rural area last week, and bringing a specialist service to that area is really rewarding. And we would like to say that anyone in that area has access to specialist palliative care. We have a lot of non-malignant disease coming onto our service. We also have an older population and an older workforce. So I'm probably one of the younger ones in the team that I work in. And I think that that's probably going to stay that way as people often come to this specialty, this place of work later in life when they've had a bit more life experience. So the definition of palliative care is an approach, which is in bold there, not a branch of medicine or nursing, but it is an approach that improves the quality of life of patients and their families whanau facing problems associated with life-limiting or life-threatening conditions. And what we do is we try to prevent and relieve suffering by early detection and assessment and treatment, not just of physical things, but all aspects to somebody, and that's what makes them human. So let's look at 10 myths of palliative care. I really like this slide. Talking about sex doesn't make you pregnant, and talking about dying doesn't make you dead. So seeing a palliative care service or a specialist or a nurse does not mean that anybody thinks that you're necessarily going to die in the next day or week or month. It just means that your illness is at in a trajectory of not being able to be cured, and somebody thinks that you would get value from our service. So myth number 1, palliative care hastens death. The fact that we come up your garden path and knock on the door does not mean that your death is going to come any sooner. We do not hasten death. What we do is we provide comfort, and we try to help you to get the best quality of life from diagnosis or identification of your advanced illness until the end of your life. And if we hear that people have gone skiing, like one of my patients did recently, or hot air ballooning, who was another patient 3 days before she died, or parachuting, or simply getting in the car and being able to go to work and say hello to your colleagues, we are the happiest people alongside you. So we really want you to do life and your family and whanau. And if we're hearing that we're getting people more comfortable or more able to cope with what's going on for them and allowing them to do more, then that is great. That's what we want. So that is hopefully the first myth that we're going to bust today. Palliative care does not hasten death. And in fact, there was a landmark study about 3 or 4 years ago looking at people with a particular type of lung cancer, and they did a randomized study, which meant that randomly somebody got given just palliative care or chemotherapy, and the group that just had palliative care actually lived longer. We think it was a bit of an unexpected finding for that study group, and it may not hold true for every illness, but it was heartening to see in an actual study this myth being busted, which is that palliative care hastens death. It does not hasten death at all. Now I just want to talk about the fact that we don't really just look after cancer. Cancer has traditionally been strongly linked with palliative care, and we have come up through and been supported by oncology services. But we really have thrown open the doors now, and we look after people with dementia sometimes, kidney disease, heart failure, lung failure. Now, I think the service probably looks different for those groups with more chronic illnesses than it does for cancer patients. We may come in and out of a person's care depending on their need and not stay involved for years and years depending on their trajectory, but we are available and we do add value at times for people with different illnesses. So that's just an important point, and one that I really hear a lot in the community. As soon as somebody finds out that I work in palliative care, I usually get a story about someone's relative with cancer, usually someone's elderly relative with cancer, and that's really not all that we deal with. So that's quite an important message to take from today. So myth number 2, palliative care is only for people dying of cancer. Fact, palliative care can benefit patients and their families from the time of illness, diagnosis of any illness that may shorten life. So some of the other illnesses that we deal with, we have a big group with motor neurone disease, heart failure, emphysema, the odd patient with Huntington's disease, different dementias, liver failure. We have a raft of illnesses that we might be involved with. Myth number 3. People in palliative care who stop eating die of starvation. Now, this is not something that we see. As an illness advances, the body actually cannot deal with a whole lot of food and fluid. As a person becomes closer to the end of their life, the different organs are winding down, and that includes the gut and the kidneys. And it will send messages to that person that they're really not hungry and they're really not thirsty. This is nature at its best. It's telling the person what it can and cannot handle. Giving somebody food when they really don't feel like it and they're approaching the end of their life makes them feel bloated and nauseated and can actually make them feel worse. So I talk about the fact that people need to be given food and fluid as their body feels like it can manage, particularly as they become weaker and more frail. It's not starvation. In fact, people who are caught on a mountaintop or out to sea with no food have completely different physiology or things going on in their body without food than somebody who's at the end of their life without food. It is not a starvation. It is actually nature's way of getting the body prepared. Okay, this is a picture of Eastgate Mall, which is one of the malls here in Christchurch. And the reason I've got this picture here is because I saw a patient here, because that's where she wanted to meet me. And so this is the next myth. Palliative care is only provided in a hospital. And basically, I will provide palliative care wherever somebody wants to meet me. So I've been to 2 food courts, I've been to somebody's workplace, and basically I'm happy to talk with somebody if they feel comfortable, wherever. Palliative care can be provided at home, it can be provided in a residential care facility, obviously in a hospice or in a hospital. But really the message is that it's not just in hospital, it's really anywhere where someone wants to and feels comfortable. The top picture there is somebody at home surrounded by their family. There's even a cat on the bed. So the pets have been involved in this picture as well. And you can see that there's a young girl kneeling by the bed. And the other picture is of a door open. And the reason I have these pictures here is for myth number 5. We need to protect children from being exposed to death and dying. And I would really implore you not to hold back or allow children the opportunity to ask what is going on. It is actually much, much better to be open and honest with children, and that needs to look different depending on their age. So even quite a small child can get some understanding, but obviously as they get older and teenagers, trying to hide things from them, they generally get a feeling that something's being hidden from them and they can feel worse. And quite often smaller children think if mum's sick or auntie's sick or grandma's sick, is it something to do with them? Have they done something? And they can wonder and feel worried if somebody doesn't explain to them what's going on. So I think it's really important to keep it open and honest with children and allow them to ask questions. They're very black and white sometimes, and we'll ask some pretty blunt questions. But it's much better to have it open and honest than to hide things. It also allows them to say goodbye and to say things that they need to, and they develop healthy attitudes about death and dying. Quite commonly, farming kids have a much more open view of death and dying because they've seen the animals on the farm, but city kids perhaps not so much. So I really do feel that this is important, that we keep things open for children. This is Jackie, and Jackie was a patient of mine when I worked in Australia actually. She was in her late 50s, early 60s, and you can see there that although she's not smiling, she looks reasonably comfortable. So myth number 6 is pain is part of dying. Now this is a very strong myth in the community. I think because of our media and because of what's in the movies and various visual things that we see. But pain is not inevitable at the end of life. In fact, quite a lot of people I deal with have no pain at all. They may have a bit of tightness or a bit of discomfort, or being in bed more means they get a bit stiff. But agonising pain or even severe, moderate pain, mild pain is not inevitable at the end of life. So this is very, very important for people to know. Often those with cancer just think it's going to be part of the journey, if you like, and it's not true. It's not true. If there is pain, there's many different ways that we can alleviate it, and I've got a couple of pictures there. One of tablets, obviously medication, oral medication. There's actually other ways of delivering medication when people can't swallow, finding tablets, and you can see the little picture there of a Nicky 34 syringe driver, and we use this. Not everybody has to have one. That's another important point. But when we do need it, it's very, very handy. It's very small and can be used at home, and you can have things for nausea, things for pain, things for restlessness or agitation in in the syringe and it gets changed each day. We only use the medication that we need and in the doses that we need as well. So this is part of the, I guess, the health system and the professionals helping a family to make sure somebody's as comfortable as possible. But it's really important to understand that pain is not inevitable. The other thing is that pain medications and palliative care lead to addiction. And again, this is untrue, completely untrue. We very rarely, if ever, see people with true life-limiting, advancing disease getting addicted to medication, particularly for their pain. When someone has true pain and they take pain medication, the body, it's almost like soaks it up. It's not over and above what they need. There's no high involved. Quite a lot of my patients have said to me, I don't know why anyone takes the stuff to get a high. I don't get a high. And that's true. So it's very, very rare for us to see patients abusing or getting addicted to pain medication. Sometimes we have to increase the dose, and that's because the disease is advancing most of the time. That's not because they're feeding a habit or getting addicted. So this is a really important point. Often families get really worried about their loved ones going on to strong pain relief, but if they need it and it's been prescribed correctly and appropriately, then they need to have it so that they can be comfortable. I think the important thing is to see it as an enabler rather than a barrier, that they're using the pain medication in appropriate ways to allow your loved one or yourself to get relief so that you can actually do life better. So this is quite an important point. It's a total myth that taking pain medications and palliative care leads to addiction. So here we have somebody driving, and the ANZ logo there is patients that I've had that have worked in a bank and also still doing businesses and leading businesses on computers from home. And that's despite having pain medication. So morphine in its appropriate doses and with the right monitoring does not hasten death. Again, I hear this all the time from the community. It is not true. If it is given appropriately, given the right way, generally we prefer giving it by tablets or capsules, and we monitor it. Sometimes we use the Mickey 34 that I just showed you to give the medications under the skin. If somebody's been on morphine for more than 2 weeks, it is actually extremely hard to hasten their death with morphine. All right, it's actually not a medication that is used anywhere to hasten people's death. So that's a bit of a myth as well. It needs to be given appropriately in appropriate doses, and it needs to be given in a way that minimises side effects. But it is a very good medication to get people comfortable and able to do things. Just needs to be given the right way. Okay, almost finished. This is the cartoon for my next slide. Someday we will all die, Snoopy. True, but on all the other days, we will not. And it's really important to know that palliative care does not mean that your doctor's given up and that there's no hope for you. It doesn't mean that at all. In fact, palliative care is not only for those who are imminently dying. I met somebody, I have a patient at the moment who's dying of a non-cancer diagnosis, who I met in 2010. And he actually improved, and we discharged him off the service, and we hadn't heard about him for several years, and then earlier this year he was referred to us, and he probably is in his final weeks now. But it was really nice to see him again, and we had a good relationship last time, and it was appropriate that he was discharged from our service. we did a lot of work with him in 2010, and he stabilised again. So there are patients that I have currently that I've known for over a year, 2 years, 3 years, and so that's quite important looking forward. It's also important to understand that you can continue having treatment for whatever your illness is alongside having palliative care. Now, this isn't the same across the world. In America, you have to relinquish treatment really to be eligible to get hospice services. But here in New Zealand, we work alongside whatever specialist is looking after you and your GP, and we don't require you to stop having active treatment. We'll walk alongside you. If there's no cure, the whole aspect of hope, it may shift to living the rest of your life as well as possible, as opposed to trying to get more and more days out of whatever treatment that you're on. So it's really just a shift in focus. It doesn't mean that anything necessarily has to be stopped. And I guess the final myth, the one, again, that even many of my colleagues perhaps don't fully understand, is the difference between withdrawing and or withholding treatments and assisting someone to die. They're actually completely different things. They're completely different ethically, medically, morally. So this is something that I just want to explain a little bit. And it's actually a patient who taught me this. So here you go. I met a 94-year-old lady in a residential care facility with very severe heart failure, on lots and lots of heart failure medication. And she asked to see me. I went in and her daughter was with her, who was probably in her 70s. She said to me, "I want you to stop all my medication. I've had enough of taking them." I said, "Okay." She said, "Really?" I said, "If that's what you wish. Have you thought about it?" And she said, "I've been thinking about it for a long time, and I really feel like it's time that I stop those medications." I said, "When would you like to do that?" "Tomorrow, the next day." She said, "Really? Are you really going to let me stop those medications? Because there's no other person that's let me do that." I said, "It's your choice. You are allowed to withdraw and refuse your medications, but let's make sure that you're going to be comfortable after you stop. Let's make sure that everybody's on the same page." She said to me, "Did you know that in any other century, I wouldn't be here now?" And I've thought about it a lot since she said that. And that's how I understand withdrawing and withholding treatments. The cause of death is the illness. The illness is what stops the heart, stops the lungs, stops the person from breathing. With assisted dying, however, it's not the illness that causes the death. It's an injection or some other artificial means. And so that's really the distinction between withdrawing, withholding treatments and assisted dying. So the picture I have there is of someone on a ventilator. Now, taking that ventilator off will cause that person to die, but it's not assisted dying. It's the illness that's causing the person to die, not putting an IV line in and giving a lethal injection. It's quite a hard concept perhaps, but I think that patient, that 94-year-old lady, taught me the distinction by saying that in any other century, that person who was on a ventilator would actually have not survived that illness and would have died a natural death. So that's the end, really. Our 10 myths. Hopefully we've myth busted today. Hopefully you got 1 or 2 bits of information from that, and I'm really happy to take questions or comments from those of you listening.
Right, so now some questions. Okay, quite a few people are asking whether palliative care is possible in people's homes.
Well, I'm a community-based physician, so I only see people at home, but depends where you live. It's likely that if you live, well, it's probably there's going to be a hospice service that covers your particular region. So you could even Google hospices in New Zealand and you'll find one that probably has a community team. Some of the hospices like Taupo only have community-based services. So they come to your home and help care for your loved one with you. There's no such thing as 24-hour government-funded care. So it does always rely on families to do, the lion's share, but there should be help and support available to you. District nurses do the bulk of our palliative care in the home here, and then we support them with any complex needs. Hopefully that answers your question.
Okay.
Sorry?
Do people have a higher tolerance of drugs like morphine? Is that why it's hard to hasten their death with morphine?
Yeah, well, because we actually make our own morphine naturally, which are called endorphins. You know, athletes, when they train every day, they get that sort of natural high. Well, that's actually our own morphine that we make in our bodies, which is why we have the kind of receptors, the way of processing it in our bodies. So there is already some circulating around, and we're really supplementing it with any extra that we put in. And it just means that the body gets used to it enough that it's actually quite hard to overdose somebody, particularly with tablets. We don't use IV morphine at all in the community or in the hospice. So we really just use it by tablet or under the skin if we need to. And as long as it's appropriate doses, then people should be okay.
Okay, here's another one. Are all doctors required to do a placement in palliative care?
No, they're not. And actually, we're a very small specialty with not a lot of kudos. So I was employed by the University of Otago 3 years ago, and at that time I was the only one employed in the country, and I'm employed 0.2, so 1 day a week. Since then, someone in Auckland's been employed even less than me. And this year is the first time I've been given the medical students on my own for 8 hours of the year. So we have had trouble getting into the medical school program and trouble kind of getting people to understand how important we are. So it's coming slowly, but it's probably people like yourselves that will get the message out quicker than us having to teach all the doctors coming through. There's definitely much more awareness now, and my boss, who's been in Christchurch Hospital for several years now, has a really good reputation, and people do come to lots of her teachings and education. So we're getting there slowly.
Okay, how do you get on with people who have been using alternative medications, such as cannabis?
I try to engender a really open and honest relationship. I want them to tell me. It is illegal, obviously, but I would rather know it's happening. My general philosophy around alternative medicines is if they don't bankrupt you and they're not harming you, then it's up to you. So the problem is sometimes it does bankrupt people, particularly those that go overseas seeking alternative treatments. They're often away from their loved ones for a period of time, which really worries me. And also if it's harming them, so we can see that whoever's prescribing it or kind of encouraging it is actually causing harm, and that's really, really tricky. But ultimately, autonomy is huge in our society. People want to choose, they want choice. And so all I can do is suggest or let people know, if I'm asked, my opinion, and minimise harm and risk, really. But there is I would say close to 100% of patients I involved with now have some sort of alternative therapy in the cupboard. Cannabis is not really what I call an alternative treatment. It's a complementary one. And it is a medicine, and we actually don't know what interactions it has. We don't know what it does in the body with somebody who's so unwell. So I'm suggesting to people that they not have it, particularly if it's recreational cannabis for medicinal use. There's only the one product really that's available called Sativex, which is the nasal spray. It's $1,300 a month. So there's only one of my patients that's managed to afford it. I'm not sure it's worked particularly. So what tends to happen is people are just getting it off the street, recreational cannabis, and using it medicinally, and that worries me because we don't really know what they're having.
Okay. Vicky asks, when my mum went to hospice, the doctor told me she was near dying, and she was. How did she know? Or how can a person know that they're dying?
Probably the webinar I did 2 weeks ago might have talked to you about that more. It's about the signs and symptoms that we see as the body's winding down and quite close to death. So we see a lot of things like breathing changes, skin changes, mobility. Sometimes we see swelling in the legs. Yeah, we get pretty adept at picking the different signs and symptoms of when somebody's quite close. So, yeah, I would have hoped they'd been perhaps pointed out to you. But if they weren't, then they were probably there that the staff were used to seeing. And there are some general things that happen as people approach the end of their life.
For the benefit of people who missed Dr. Landa's previous webinar, it's on our website, livinganddying.org.nz. Here's another comment. Marie says, when my father was dying in a rest home, his doctor decided he needed the pain relief under the skin. As he was having it put in, he was praying and was obviously very distressed. The next day, the pump actually ran out and started beeping, which was also very distressing. I've always felt guilty for not questioning the need for that, as the previous few days he had been quite coherent and almost at peace. He had a very strong faith. What would you say to that?
It's a little hard to know. It could be that the syringe driver went up because he started showing some signs of being agitated, or it may be because he lost his ability to swallow. And so the staff knew that they needed to be able to give him medications in different ways. There may have been signs and symptoms to them that he was quite close to the end of his life. When it beeps, it's actually still got about 2 hours worth of medication in the bloodstream. So it doesn't need to be changed absolutely immediately. It's actually still in the line. It's still circulating in the system. So there would have been some time, even when it was beeping, that he would still have had the medication on board. Hopefully that helps.
Any thoughts on why he may have been incoherent during
yes,
the last few days?
It comes back to the webinar I gave a couple of weeks ago around as the body's dying, as the organs are winding down, the brain starts to wind down too as part of that process, and people get less and less able to communicate and can get quite restless. And we call that terminal restlessness or terminal agitation, which I know I already said to you earlier I didn't like that term, but that's a term that's used across the world. And it's one where we know people are really in their last 24, 48 hours, and they really need to have muscle relaxant, not morphine, but muscle relaxant to help with that so it's not distressing for families. So he may have started to show some signs of terminal restlessness or the brain winding down, and then it sounds to me like they probably did the right thing.
Okay, another question. Is there a certain amount of dying funding or palliative care funding allocated to each person?
Oh, to each person. Well, we're a free service. People don't pay for us. But we're only 70% government funded, so we're not seen as an essential service by the health system, which I find interesting. So we have to fundraise 30% of all our costs. So The hospice I worked for in Wellington had to raise $1 million a year just to be able to operate, not for any extra kind of cherry on the top things. I'm not sure about the hospice here, how much they have to fundraise, but we do to be able to survive, which is why you see hospice shops all over the place. So there's not funding per person, but it's free for all New Zealanders, hospice services, community services, things like anything under $50, like a urinal bottle or something like that, we do ask the families to pay for. But the big items, things like having a hospital bed at home or a lazy boy chair at home if you need one, we pay for that. That gets paid for. So it's actually a pretty good service. Quite often patients are trying to pay us or pay the hospice when they leave, but we're a free service.
If people get hospital beds and lazy boy chairs, are they on loan or do they then belong to the person and their family?
They're on loan. They're on loan. And then what happens, well, here anyway, is that the family lets usually the occupational therapist or the community service know, and after the person's died, the equipment gets picked up and the family don't have to worry about it then. So, yeah, generally it's on loan.
Okay, a follow-up comment from Marie regarding her restless father. She says, "Thank you. He certainly was restless in his last few hours. Your explanation has made me feel better."
Yeah, I think it sounds like all the right things happened.
Here's another question. Do you think if euthanasia is introduced, legalized, that the funding for palliative care would be reduced?
Yes. It's a little difficult to know. Some will say that in the Netherlands and Belgium the funding went up, but I read a paper recently about Oregon, because obviously it's been legal in Oregon for quite some time now, and Oregon, the state of Oregon, used to be a shining light for palliative care services in America, sort of pre the euthanasia bill, and it's quite worrying because their rate of growth of palliative care services has really dropped off the national average. So they're no longer the shining light state that they used to be. It's hard to know, partly because I don't think we can extrapolate what happens in other countries to here, and that's part of the issue of bringing euthanasia legislation in. You know, we think it's, you know, it's working well or whatever you want to say in a different country, but I'm not sure we can transplant it to our situation here in New Zealand and think it will happen the same way. We're quite a different culture. We're actually quite a different culture even to Australia. So it's a little hard to be sure, but I don't think it follows that we'll get all this amazing funding if euthanasia is legalised in New Zealand. I don't think we couldn't say that.
Is it true that most palliative care physicians are opposed to euthanasia? And if so, why is that?
It's definitely true. And the reason I can say that confidently is because we had a membership vote in our specialty society. So that's all the palliative care doctors in Australia and New Zealand had a vote for its position statement. And the New Zealand percentages were quite a bit higher than the Australian ones, but they were both vastly in the majority against. The reason we tend to be opposed to it is because we're so close and working in it, and we can see the potential problems and issues. When we can see problems with like coercion and people feeling like a burden already, you know, all the issues that get talked about on the anti-side, we actually see and are involved in and worry about. And we also see beautiful deaths. Like, I know that seems strange, but we do. We see amazing things happen in families. We see transformation of families, you know, people who haven't talked to each other for years. It's truly incredible what happens when that process is allowed to happen naturally, not just for the person themselves, but their families and, yeah, even wider than that. So I think because we're in it and we see the positives and we see the transformation. Lots of our colleagues don't. And it's pretty well known that as you move out as a doctor from dealing with people at the end of life, you're more likely to be pro-euthanasia. As you come in and us doctors that are very close to working with those at the end of their lives, they're much more likely to be anti. So the British Geriatric Society came out with a very strong position statement last year against euthanasia. So that's the doctors who look after those at the older age groups, and obviously have a lot to do with end-of-life care. So I think it's truly just experience and understanding the issues.
Okay. Dr. Landis, what would you say to the family members of people who are receiving palliative care?
I say lots of things. What I tell them is kind of to find the rhythm of their loved one. If their loved one's tired, let them sleep. Just be with them. You don't have to fix anything or do anything. If your loved one doesn't feel like eating, that's okay. Put the food back in the fridge and maybe bring it out again a bit later and see if they want it. If your relative is crying, then it's okay. Let them cry. It's all right to be sad. It doesn't mean they're necessarily depressed or suffering terribly. It just means that that moment in time they're sad, and a bit of a soft touch or sitting with somebody is okay and just as important as any medication. And I think what I try hard to promote is open and honest discussion, because the biggest gift that your loved one can give a family is knowledge of what they want. And so if you can promote that in a family, then they come to a better level of acceptance and understanding quicker. It's the families that try and hide and protect each other and leave the elephant in the room that really can struggle. So that's probably my biggest message to families is allow space and time to talk, to relax into the person's rhythm, and yeah, try not to get too, and I guess arm yourself with the knowledge of what's normal about the dying process so that you're not worried about things that we would expect.
Okay, here's another question. Dr. Landis, I know we were talking about euthanasia. What is your take on euthanasia in the case of dementia, where the person has advanced care planning, an advanced care plan, requesting that if it became legal in their lifetime, they wanted to be euthanized?
All right, so you're talking about a situation where someone has an advance directive saying that if they become incapacitated, they want euthanasia, and then they become incapacitated secondary to dementia, so they can no longer competently say yes or no. I assume that's
yes,
the case.
Yeah, that sounds like it.
It's pretty fraught, and even the most hardened pro-euthanasia advocate will tell you it's pretty fraught. And there's been some cases overseas with that very case where the person has said, I don't want to die, and they've been euthanized anyway. And that makes it even more fraught. I'm going to say something that's probably going to surprise everybody. And what I'm going to say is the two ways that of dying that we fear the most, I think, in our society is cancer and dementia. And actually, they're probably the best ways to die. And the reason I say that is because cancer, you tend to have time. You tend to have time to spend with your family and to process what's going on with you and to tie up any loose ends if we have loose ends and all of those kind of cliche things. People with dementia are actually quite often happy. They lead simple lives. They sleep a lot. They get fed and looked after. We have a residential care facility on site here. Most of the patients have significant dementia. They're warm. they're looked after, they have dignity, they're comfortable, and the most distress is actually for families because that person's no longer the person that they remember. But a lot of the fear of dementia comes from the well and comes from the family. And so to euthanize somebody who's comfortable and dignified and really had no understanding when they wrote that advance directive of what having dementia was going to mean actually feels quite scary to me.
Well, thank you very much, Dr. Landers. Our time is up, and thank you very much to everyone who's joined in. We'll send you the link to the replay as well. I'll just comment from the person who asked the last question before we go. She says, I understand. Thank you so much. You have helped an internal dilemma. As a person who works in aged care, I get asked time and time again my opinion, and my stance is I provide optimum quality care, and at the end of the day, that is what matters to me. Thank you very much for that comment. Well, thank you very much, Dr. Landers, and thanks to everyone. Bye.